Hello, and thank you for joining our educational webinar today with Dr. Stephen Sharp. We will discuss the importance of early screenings for colon and rectal conditions, as well as the latest treatment options that are most effective and improve patient recovery. I'm Leslie Hartz, and I'm the member of VCU Health marketing team. Before we begin the presentation, I'd like to note that we will hold all questions until the end. Please feel free to drop any questions you have in the Facebook comment section throughout the event. We will address them during the Q&A portion. Now to introduce our speaker, Dr. Sharp is a colon and rectal surgeon with particular interests in minimally invasive colorectal surgery, treating colorectal and anal cancer, and the surgical management for diseases like inflammatory bowel disease. He also participates in research and is interested in surgical outcomes research for benign and malignant colorectal conditions, as well as a colorectal racial disparities research. Thank you, Dr. Sharp, for joining us today. I'll turn the show over to you.
Thank you so much, Leslie, and thank you everyone for joining in with us this evening. Again, my name is Dr. Sharp, and I'm going to be talking about screening for colorectal cancer. Actually, this is something that we see very frequently in patients that oftentimes we see patients when they haven't had their screening and they present oftentimes very, very late with advanced stage cancer. So I think that it's something that's very important to discuss with the general public, because colorectal cancer is something that can be prevented actually. And March is actually, we just finished with the Colorectal Cancer Awareness Month. And so this goes very well with something that is near and dear to my heart, because this is something that can be prevented in patients. Next slide, please. Today I'm going to be discussing why screening colonoscopy is done, when it's done, how it's done, where it's done here at VCU, how safe it is, what to expect during the procedure, and go over some common misconceptions that patients have regarding screening colonoscopy, and then finally discuss some special circumstances in situations where colonoscopy may need to be done sooner than the age that's normally recommended. Next slide, please. So the reason that colonoscopy is done for screening, colon cancer screening, is that it actually saves lives. Colonoscopy and colorectal cancer is one of the few conditions that we see that the condition can actually be prevented by having colonoscopy performed. Studies have shown that colonoscopy can reduce the risk of death from right-sided colorectal cancer by as much as 46%, and left-sided cancer by 72%. So in terms of preventable diseases, colorectal cancer is something that can be prevented through the use of colonoscopy to try to remove small growths before they turn into large cancers. And so this is something that that is not done as frequently as we would like to see within the general public. And it's something, that's why I wanted to discuss it today, to hopefully raise patients' awareness about why, when, and how this is done. Next slide, please. So colorectal cancer is something that does not develop within a day, a week, or even a year. Colorectal cancer starts as a very small polyp called an adenoma within the colon, and these develop over time into larger adenomas and eventually progress into a cancer. And this process typically takes anywhere from 2 to 5 years to occur. And so the reason behind doing early colonoscopy is that these small adenomas or growths can be removed at the time of colonoscopy and prevent the progression of a cancer from developing. Next slide, please. Again, this is another schematic here that shows that these cancers arise from a small polyp, and these polyps are typically, when we can see them on colonoscopy, are approximately the size of a small pea. And these can be very easily removed during colonoscopy, and this prevents a cancer from growing in this location. Next slide. This is a cartoon schematic about how the polyps are removed during colonoscopy. There's typically either a snare or a biopsy forceps that is placed through one of the lumens of the colonoscope, and this is removed endoluminally and then sent to the pathologist to be further evaluated. Next slide, please. So for patients with average risk of colon cancer, screening is now recommended to start at the age of 45 years of age. It used to be 50, but now studies have shown that the risk of colorectal cancer is becoming higher in younger patients, and so the recommendations have recently been changed in the last couple of years to go down to 45 years of age. Now, in patients that have a higher risk of colon cancer, such as a family history of colon cancer, family history of colon polyps, or a history of inflammatory bowel disease, the timing of the first recommended age of colonoscopy depends on certain circumstances. In cases with a first-degree relative with a history of colon cancer, the age is typically recommended 10 years prior to the diagnosis. So if you're, say, one of your brothers or sisters, mom or dad had a colon cancer that was diagnosed at the age of 50, then the first recommended colonoscopy for you would be at the age of 40, 10 years before the age of diagnosis of that patient. Next slide, please. So now I have a video that we're going to play going over an overview of colonoscopy, how it's performed, some cartoons of what the procedure is like, and gives a good background about the overview of it. Are you able to play the audio from the video there? So this is showing what a colonoscope is. It's a flexible device that's placed into the colon, and there's a light at the end of it. And the colonoscope is advanced through the colon to the cecum. And in some cases, it is advanced into the terminal ileum. So the tip of the colonoscope has a video camera. It has a channel for irrigation so that stool can be cleaned, residual stool can be cleaned from the colon. Also has light at the end, and then there's a biopsy channel where the biopsy forceps or the snare are able to be passed through the scope and to remove or biopsy any lesions that are encountered. This is just showing a schematic of how a polyp is removed. And again, this polyp is sent to the pathologist to examine it. A colonoscopy takes approximately 30 to 60 minutes. It's performed by either a gastroenterologist or a colorectal surgeon, such as myself. The patient is asleep during the procedure. We use sedative medication, usually propofol. It works very quickly and it wears off very quickly. And this has been shown to patients have a better experience during their colonoscopy, less complaints of pain afterwards. and we're able to get a very good exam of the inside of the colon. This shows, there's a video screen that shows the inside of the colon here as we advance the colonoscope through the colon. The colon is gently expanded with air that is resorbed by the body as we go into the colon. And we're able to get a very thorough examination of the lining to see if there's any abnormal areas or polyps that need to be either removed or biopsied. And again, these are sent off to the pathologist for further evaluation. There's different types of polyps, and depending on the type of polyp and how many polyps are removed, we have a good idea of when to repeat a colonoscopy in order to prevent any further growths from arising, turning into cancer. So after the colonoscopy is performed, recovery typically takes about 30 minutes as you wake up. I always tell patients if there's anything that we biopsy or remove, typically we'll come and talk with the patient afterwards. You do need to have someone to drive you home afterwards because of the sedation. And then typically the gastroenterologist or physician or surgeon's office will be calling you to give results of the biopsies and when to have your next colonoscopy done. Typically, follow-up instructions and things to watch out for are severe abdominal pain and severe bleeding. Colonoscopy is very safe, as I'll discuss in a little bit. Major complications could involve significant amount of bleeding, particularly if there's a very large mass or polyp that's removed, and in patients with blood thinners who resume their blood thinners. Other things to watch out for: fever, nausea, vomiting, and worsening abdominal pain. All right, we can go to the next slide. Okay, so where it's done. So VCU Health is in the process of opening a new endoscopy center at 9105 Stony Point. And this will be very convenient for patients because it's parking is much easier. It's much easier in and out. And it's a much smaller center. So it's not the downtown with the parking can sometimes be a little bit of an issue for patients. So this will definitely be a positive. We will still be doing endoscopies downtown, and we also perform them at VCU Tappahannock. Next slide, please. So going back to the safety of colonoscopy, overall colonoscopy is very safe. The likelihood of having a major complication after colonoscopy is probably on the order of 1 in 1,000. So it's a very safe procedure. Typically, the major risks are severe bleeding requiring a blood transfusion, if there's a large mass that needs to be removed, or extremely unlikely is perforation, which is a tearing of the bowel that occurs during the colonoscopy. And this is fortunately very, very rare. And if it were to occur, does not always need surgery, but sometimes does. But again, that's something that's extremely rare, and for providers who are perform colonoscopies regularly, fortunately, this is something that's very rare. We have good feedback when we're doing the procedure. If there's a risk of creating a perforation, then the provider will stop and we'll discuss other alternative methods of evaluating the colon to decrease the risk of that happening. Probably the more common side effects are related to the anesthesia and the recovery of that. And also some patients can experience some abdominal discomfort or bloating for a couple of days after the procedure is done. Next slide, please. So as far as what to expect during and after your colonoscopy, the procedure typically takes 20 to 30 minutes. You do need to have someone to drive you home afterwards. I tell patients that they're able to return to work the day after the procedure, and once the results of the colonoscopy are back, your provider should send you a letter or a message telling you when to have your next colonoscopy scheduled. Biopsies typically take about 5 to 7 days to process by the pathologist. And sometimes your provider won't know when to have your next colonoscopy done until they review the pathology from the biopsies. And as I said previously, major signs and symptoms that warrant a phone call to your doctor or coming back to the emergency room are things such as fevers or chills, major bleeding, or severe worsening abdominal pain. Next slide, please. So some of the common misconceptions about colonoscopy that we hear from patients, number one is patients are concerned about the cost. Fortunately, most insurance companies and also Medicare and Medicaid would cover screening colonoscopies. So cost is typically not an issue for most patients. The next thing is the prep. This is oftentimes the most worrisome part of the colonoscopy, and a reason why a lot of people don't have it done, because they've heard stories from their parents or grandparents saying that they had to drink a giant jug of disgusting tasting liquid and that they were in the bathroom the entire day, and it was a very miserable experience. Fortunately, now the types of colon preparation that are used are much more gentle on the system. They're lower volumes, they don't taste as bad, and typically patients do not tolerate the newer preps much better. So this is something to bring up with your the provider who's going to be doing the procedure for you. Discuss with their office what the different types of prep are, and typically, again, these are much more easily tolerated compared to 10 or 15 years ago. Some people say that the wait is too long to get an appointment. I can tell you with knowing our office that we are able to get patients scheduled within a week or two for colonoscopies. There's within the colorectal section here, there are 4 of us who perform colonoscopies regularly, and we have a lot of available slots, and that number is going to increase with the new 9105 testing center. So that is something, the scheduling, that we're very easily able to accommodate with your work schedule. Some people think it's embarrassing. Nothing is farther from the truth. What is something that should not be embarrassing is that this is done to prevent the development of cancer. And so what is a 30 to 60 minute procedure can prevent a major invasive cancer 10 years down the line, and can make your life a lot easier. And that's why we recommend having these done, is to prevent the development of cancer down the road. As far as the time it takes, I tell people it usually is about 2 days out of your schedule. So it's a day to do the prep and a day for the procedure, to have someone drive you. And again, 2 days to have something done to prevent the development of a cancer is something that is, in my opinion, time well spent. And so that's something that should not be a deterrent. I understand everyone's busy and we have a lot of stuff going on, but your health should be taken first and foremost above those things. Next slide, please. So some special circumstances to note. Number one, as I alluded to earlier, family history of colon cancer, polyps. This you should discuss with your doctor as part of your history, and that this will dictate when you should have your first colonoscopy. So the average age, as I said previously, is 45 years of age to have your first colonoscopy done. If you have a family history of colon cancer, colon polyps, other situations, this age is going to change most likely. And in some cases, we recommend screening for cancer in patients in their teens and 20s, depending on the situation. So patients with familial cancer syndrome, such as HNPCC, the evaluation for cancer needs to be done much earlier, as early as the early 20s. Patients who have history of ulcerative colitis or Crohn's disease, these conditions predispose to slightly higher risk of colorectal cancer. And so typically annual colonoscopic evaluation is done starting approximately 5 to 8 years after the initial diagnosis, in order to screen for cancer. And the last thing that I'll talk about is early onset colorectal cancer. And this is a reason why the screening age was changed from 50 to 45 years of age, because we're seeing such an uptick in the number of young patients diagnosed with colorectal cancer. And the reasons behind this are not entirely clear. It's a multifactorial situation: genetics, diet, environmental things. And so I've seen patients, as early as their early 30s that were sent to me for quote unquote hemorrhoids and bleeding, and turned out that they had a cancer in their colon. And so this is something that if I always tell patients, if you notice blood in your stool or blood in the toilet bowl, that happens more than once, especially over a 2-week period, more than that, you need to talk with your doctor about this, because even for patients who are young and otherwise totally healthy, this is something that needs to be taken seriously. And that I think it's important for patients for the general public to understand that this is going on, because we even see it within our practice that patients go to their primary doctor and the primary doctor says, no, it's just your hemorrhoids, take some fiber. And it turns out that, most patients, there's not something going on, but there's a few patients that will find a cancer there. And it's something that fortunately can be treated very locally with surgery through minimally invasive techniques, and they have a good outcome. But this is something that providers and also the general public needs to be aware of. Next slide, please. So I want to thank you for your attention and appreciate taking the time. And right now we're going to go through some questions. Leslie.
Yes, thank you so much, Dr. Sharp, for that very informative seminar. We now will open the floor for comments and questions. Before I address the questions, I would like to read a few that were submitted beforehand. So the first here is, what are the early signs of colon cancer?
So very early on, there may be very minimal to no signs of cancer. And again, this is why, going back to the idea of screening colonoscopy so that these can be found early, because early on there will be no signs or symptoms of it. As the cancer gets larger, patients may notice blood in their stool. They may notice blood in the toilet bowl. And as the cancer progresses and enlarges, they may notice worsening abdominal discomfort, bloating, a change in their stool caliber. A lot of patients will come to me before they've been diagnosed and say, I've had to start taking more laxatives in order to have a bowel movement. So there will be change in caliber. But again, those are things that are late signs. So going back to why to do colonoscopy early, it's so that we can detect polyps and cancers before they get to that stage.
Right. Very important. We mentioned, can it be prevented? And I think you just answered that question.
Absolutely. No, this is one of those few situations that we can have a significant impact in preventing colorectal cancer. There are I'm sure there will be other questions that come up about this, but with this technique, this is something that has a very direct impact on preventing polyps from turning into cancers.
Exactly. Another question came in here. What lifestyle changes can people make to help to lower their risks and prevent colorectal cancer from even developing?
So there's a few things that we can do, and generally this goes hand in hand with healthy lifestyle and healthy living. So eating a healthy, balanced diet that's high in fiber, and also avoiding red meat, avoiding smoking, and exercising regularly, and trying to control our weight. Obesity is something that's also associated with increased risk of colorectal cancer. So those are, I always tell patients, there are things that are within our control, things that are outside of our control. So the things that are outside of our control are our genetics and some of the environmental factors. And these are things that we just discussed that are within our control. And this goes outside the scope of colon cancer, but just is, gives you a much healthier body overall, lowers things like diabetes, risk of, lung cancer, other cancers. So it's not just with colorectal cancer, but these lifestyle modifications can also improve our health outcomes from many different facets.
Right, absolutely. When should folks start getting routine colorectal screenings?
As I talked about before, the age now is 45. And those are for average risk patients with no family history and who have no signs or symptoms. So just because you're not at the age of 45, if you have other changes that are going on, you should talk with your doctor about that. Things like change in your bowel habits, things like blood in your stool, unintentional weight loss. Those are signs that you may need to have a colonoscopy done prior to the age of 45.
Okay. And looks like one more question. What is the difference between a colectomy and colonoscopy?
So a colectomy is a surgical procedure where we remove a portion of the colon and reconnect the two ends. And so, and that would be done for various indications, such as a colon cancer. And a colonoscopy is a procedure where it's not considered a major surgery, and the patients are given sedation, and it's a same day procedure. A colectomy is again a major surgery, and you'd be visiting a surgeon specifically for that. That would not be done by a gastroenterologist, and then you would need to come in. You would be admitted to the hospital afterwards.
Gotcha. So even though they sounded like very different things.
Yes.
Well, we can't thank you enough for being here today and having this really valuable discussion. It's, as you said, it's common for these conditions to go untreated, and many are very unfamiliar with the symptoms or feel too self-conscious to talk about it. So please, everyone listening, don't hesitate to seek help from your doctors if you're having any of these symptoms, or if you're just worried, or remember, age 45. For more information about colon and rectal surgery at VCU Health, visit vcuhealth.org. and follow at VCU Health on Facebook. And of course, for more information about colorectal cancer specifically, be sure to visit Massey Cancer Center at masseycancercenter.org. Once again, thank you, Dr. Sharp, and everyone who joined us today. Have a great night.
Good night.